going to hit record. We are actually already live streaming on YouTube, so that people can grab it from the channel, from the YouTube channel. All right, so I am going to hit. Okay, we're going to hit start. Start the webinar. Okay. Okay, so we have officially started. So hello, everybody, to everybody that's watching, and we have more people that are joining. For those of you who are joining us right now or will be hopping on to join us soon, you can also watch this live stream on our Game on Glio YouTube channel as well. I am here today. We are doing a panel discussion, a nice informal panel discussion with three amazing doctors in the brain cancer arena. They are all highly experienced, very well trained, very passionate about the work that we're doing. I am your moderator, Shannon Traphagen. I am the host of Game on Glio podcast and the owner of Right Life Media. I would like to briefly introduce each of our panelists today, and then they're going to tell us just a little bit more about themselves, and then we're going to jump right into the questions. For all of you that are watching, please know that questions are enabled. So if you are curious about something that we are talking about, please throw a question in the chat. I will be moderating those questions, and then the last 10 or 15 minutes of this hour session, I will grab some of those questions to throw back to the doctors. So we will be quizzing them as we go along today. So I am going to start with Dr. Michael Garcia. He is the Chief Medical Officer at GT Medical Technologies and a board-certified radiation oncologist. We also have Dr. Jay McCracken, who is a board-certified neurosurgeon at the Piedmont Atlanta Brain Tumor Center. And we have Dr. Imran Mohiuddin, who is a radiation oncologist at Advent Health Cancer Institute in Orlando. So, Dr. Garcia, I'd like to start with you. If you want to just maybe briefly tell the viewers a little bit more about yourself and your affiliation with GT Medical Technologies and GammaTile therapy specifically.
Yeah, definitely. And Shannon, I want to thank you for inviting me to be part of this podcast. And really thank you for the podcast. It's a tremendous resource for patients, families, and healthcare providers. And so thank you for all that you do. Yeah, I'm Michael Garcia. I'm a radiation oncologist, which really means I'm a cancer doctor that uses radiation to treat tumors. And I'm also the chief medical officer and head of clinical development at GT Medical Technologies, the maker of GammaTile. And we'll talk a little bit about what GammaTile is later. But here at the company, I have the privilege of helping to support all of our medical education efforts to help doctors know about GammaTile and when to use it and how to use it, and also support our clinical trials, which I'll talk about more later too. So I look forward to the next hour.
Great, thank you so much. Dr. McCracken, why don't we move over to you and have you just tell us a little bit more about your experience and how you're associated with GammaTile?
Sure. So I'm a neurosurgeon. I'm actually a neurosurgical oncologist who specializes in treatment of brain tumors, both benign and malignant. But we have used GammaTile now for about 4 years, going all the way back to January of 2020, almost all in the brain metastases, glioblastoma, and malignant meningioma space. But our centers, we've probably done about 70 cases so far.
Wow.
So I think we've got one of the larger series in the country for patients and experiences that we've treated. But at Piedmont, we see a lot of patients come through. We treat about 300 to 350 new patients a year. And so we're excited to share our experience with you guys today.
Perfect. And Dr. M, as you like to be called, tell us a little bit more about the work that you do as a radiation oncologist and how you're affiliated with GammaTile therapy.
So again, also thank you. It's an honor to be on the podcast. I tell my family I'm an X-ray doctor when they ask, and I also use X-rays and other types of radiation energy to treat cancer. I practice in Orlando in Central Florida, just by nature of the population typically being a little bit older and in a very fast-growing area. We have a very high population of cancer and of brain tumors. And so within our group, I focus specifically on the central nervous system, the brain, the spine, and use different modalities, GammaTile, Gamma Knife, and external beam radiation to treat these type of tumors. We started our GammaTile program in 2021, so a year after Jay, and we're hitting like a little over 30 cases.
Wow.
This week I did around 3 cases alone, and actually spoke to both of these gentlemen earlier today. So we're always kind of talking to each other and learning from each other.
It's a close-knit field. I've gotten very familiar with that. So we're going to jump right into this. We're going to start with Dr. Garcia. Explain to us a little bit about what GammaTile is and what makes it so innovative when it comes to treating brain cancer.
Sure. Yeah. And taking a little bit of a step back, there are brain tumors, of course, that have a propensity to come back, that are likely to come back, including glioblastoma, brain metastases, some meningiomas after surgical resection. And so, despite having a really good removal of the tumor, it's impossible for the surgeon to take out every single cell. And in these cells, they could be aggressive and they replicate and the tumor can grow back. And so that's why radiation is used and really the standard of care for these situations. After a patient has a removal of a malignant brain tumor, the standard of care has been what's called external beam radiation. Others may have heard of IMRT, for instance. It's a type of external beam radiation where the radiation comes from a machine from the outside in and treats that, what we call the tumor cavity, the tumor space where, that where the tumor no longer exists because it was removed. So what GammaTile is, it's another way of administering that radiation, but in a way that's internal. And so with external beam radiation, the patient has to heal from the surgery because those x-rays are going to be traversing the skull. But with internal radiation, with GammaTile, those radioactive tiles can be placed immediately at time of surgery so that radiation can start immediately. One of the downsides of external beam radiation is that these malignant tumors can start growing back between surgery and external beam radiation. And so GammaTile allows radiation to start immediately. GammaTile is it's a little postage size, like a postage stamp size collagen tile that has radioactive seeds in it, cesium-131. And so this tile is placed in the tumor cavity, starts radiation immediately, and over the next few weeks administers the dose, and the dose naturally decreases as the radioactivity wears away, and then the collagen tile naturally absorbs. So the patient gets about 90% of their radiation dose within 4 weeks of the surgery.
And
Usually
it starts
radiation
immediately.
external, and it starts immediately versus external beam radiation, which starts about 3 to 6 weeks after a surgery.
Wow. Wow. Dr. McCracken, as a neurosurgeon, how complicated or easy is it to install these tiles during surgery? And does it increase surgery time?
Yeah, thankfully, it's actually a tremendously easy process. It really adds no more than 5 minutes to the end of our surgical case. Really the hard part is deciding who's going to be a good candidate up front and figuring out who will benefit prior to us doing the surgery. And so, in a collaborative effort with both, our neuro-oncologist and radiation oncologist, that's really, how we figure out who to prescribe this treatment for. But ultimately, at the time of surgery, a patient will undergo a standard craniotomy for a resection of a brain tumor, just like we would, even if we were not placing, the cesium tiles. And then once the cavity has been created with removal of the brain tumor, over the course of approximately 2 to 5 minutes, we just simply line these tiles end to end, sort of in a circumferential fashion within the cavity, and then close. It really could not be easier.
How do you know how many tiles to insert? I mean, is there a standard number of tiles that you would put in, or does that depend on the size of the cavity that's there?
Yeah, it's a great question. So a lot of it is based on the size of the tumor that we're removing.
Okay.
And so we really rely on a patient's preoperative MRI to basically figure out what the volume of a tumor is going to be.
Mhm.
And then we make estimates based on, once we remove that, what the residual surface area will be within the cavity itself.
Okay.
And the number of tiles that we order and ultimately place is based on the residual surface area within the cavity.
Wow. Okay. So to build kind of on the last question, actually, no, I want to jump over to Dr. M. I'm going to call you Dr. M because it's just otherwise I'm going to screw it up at some point. I know I am. What's the efficacy around having radiation emitted right at the site of the tumor field instead of external radiation that penetrates through multiple barriers to reach the target? What's the efficacy of that?
I think we could spend an hour just on that point alone.
I know.
And to kind of build off Mike's introduction to GammaTile a few moments ago, one, this is surgically targeted radiation, right? So with someone like Dr. McCracken removing the tumor, we know exactly where that tumor used to live, and then we can place that radiation in a very precise manner exactly where it needs to go. There's tremendous benefit simply in that. External beam radiation is delivered, in principle from far away from the cavity. It traverses from the machine through the air, through the tissues, and actually to the target site. And then what kind of people forget about is actually keeps going, right? It's x-rays. It doesn't just stop. It goes through you, and it goes through the floor or through the window. And so a lot of the side effects from radiation treatment come from unnecessary tissues receiving that energy, right? So
That's
hair
being
loss,
hit
right,
by,
as this energy is traversing. So hair loss, skin side effects, brain side effects, fatigue. And then remember, remember is the wrong word, but take into consideration that external beam is delivered not just from one angle, but from many angles. It's in some instances, it's actually a continuous rotation. So you're getting this effect multiplied by every single point of entry and exit. And converse to that, GammaTile delivers the radiation where it needs to be, and it doesn't go really beyond that. It goes millimeters beyond that, and then it stops.
I was going to ask that, like once you get the tiles into the cavity, there's a certain parameter of where the radiation will hit, and then it doesn't really go beyond that radiation, that field. Is that pretty much how or will it kind of maybe
That's
traverse
correct. That's correct. And, I think that there's some points where it's beyond the scope of this conversation, but GammaTile has been specifically formulated to be of a specific energy that is just right. It's in that Goldilocks zone where it is strong enough to do what it needs to do and no stronger. And that's the way you want it. Another point that I'd like to highlight before, yielding is that external beam is pulses of energy that are given at a specific time of day, and then you come back for your next daily treatment. And that's kind of the typical scenario. There are other certain ways of giving that doesn't apply, but where this is relevant is that when we look at the biology of cancer and the biology of a cell, there's certain times in that cell cycle, thinking back to high school biology, mitosis and all of those things, we know that the cell is more radiosensitive, meaning vulnerable to radiation, and then radio resistant, where you can give a strong dose of radiation and may not actually do anything. And what's really interesting and cool about GammaTile is that it is a continuous delivery of radiation over about 3 months. The majority of the energy is within 10 days, and then another majority of the energy within 1 month, but really over 3 months for it to become inert. And what's cool is that you are essentially then exposing those cells, the potentially cancerous leftover cells, to energy throughout their cell cycle. So it is much more likely that that cell is going to be exposed in a radio-sensitive portion of its cell cycle with GammaTile than it is with external beam.
Interesting. So to follow up on that a little bit, I have a couple of just follow-up questions. This says to me that this is also easier on the patient, and any one of you can chime in for this, but it sounds like because once the tiles are in, the patient goes home and the radiation just starts working. So to kind of piggyback on that thinking, does this help? Does this make the radiation team's job easier, plus the patient and the caregiver's job easier, because they don't have to come in every single day, 4 to 5 days a week, to get their radiation treatment and then go home and then come back in and then go home? Do you feel that it makes everybody's jobs easier because they get to go home, they get to have self-care? You guys get to put the the tiles get put in, the radiation team monitors how the tiles are doing, and the patient doesn't have to be, in an office setting or in a radiation setting every single day.
I can only speak to what my experience is, and certainly going from the first case to the 30th case, it becomes a lot more natural and a lot more easy, in air quotes. But I think Jay mentioned this before, and I agree with it entirely. I think the hard part is picking the right patient. And then it becomes a matter of coordination. This is a multidisciplinary modality. What I mean is that it requires strong collaboration between a neurosurgeon, a radiation oncologist, and other components of a hospital system to pull off. So I think it's kind of comparable to like planning a really elaborate wedding, and the hard part is getting all of those things, all of those people to work together. And that can be challenging at different institutions, but then when you pull it off, it's like a beautiful thing, and everyone's having a good time, and so to speak. But I don't want to make light of the circumstance of what we're talking about, but it is, once it's in the patient, then it is easy for the patient, and I think a fundamentally different experience than coming in for daily treatments over the course of however long you need to deliver external beam for a particular diagnosis.
Yeah, I mean, I can't speak for, anybody else, but I can speak to when my husband was getting radiation. I wish we had known about GammaTile ahead of him starting radiation. Because it's intense to have to go into that setting every single day. You have a mask that's pinning your face down to get your radiation treatment. It's tiring, it's exhausting, it's a lot of work. So, I can only speak, from my experience. Dr. Garcia, how do you feel that GammaTile helps improve patient outcomes and quality of life from receiving something like GammaTile?
Yeah, it's a great question. Unfortunately, it's has been studied and is continuing to be studied. So to date, there's been over 30 peer-reviewed publications on GammaTile documenting physics characteristics of it, the technology, but most importantly, the safety and efficacy. And specifically in the realms of brain metastases, glioblastoma, and meningioma, it's important to know how safe is this to use in a brain metastasis case, and how efficacious is it to use in a brain metastasis case. And there's been numerous publications on these. And one of my favorite things about GammaTile is that it provides options to patients, especially in situations where there have been limited options in the past. For instance, when a brain tumor comes back, even after surgery and radiation, that's a very challenging tumor to treat, because reirradiation, especially with external beam, can lead to a lot of side effects, and even potentially some injury to the brain called radiation necrosis. And internal radiation, because it's so targeted and focused, and you can then give higher doses right where you need it, gives another option. And so this has been really well studied, especially for recurrent brain metastases, recurrent glioblastoma, and recurrent meningioma. And for instance, for recurrent brain metastases, the best that we've done using surgery and or external beam radiation is about a 60 to 70% local control rate at 1 year, which is not great. Yeah. But with GammaTile, from reports from Memorial Sloan Kettering, Miami Baptist, Miami Cancer Institute, and Barrow Neurological Institute, local control rates are on the order of 90 to 100% at 1 year, which is quite encouraging. Yeah. And Memorial Sloan Kettering is running a randomized study to further validate that. But so far, the evidence shows that this is a great treatment option. And I'll talk a little bit more about our clinical trials later, about how we're combining GammaTile with external beam radiation. But I would say that, the data is there and it's continuing to increase. And in terms of your quality of life question, as Imran pointed out, their patients with external beam often lose their hair. With GammaTile, we're not seeing that type of hair loss, and I think that's really important for patients.
That is important because that's
For,
definitely a trigger for a lot of patients.
Definitely.
Yeah.
And then, commuting to and from a center for radiation, oftentimes these patients, they may live out of town, and they have to travel in or stay at a hotel. All these things can be challenging for the patients. Sometimes what's the worst possibility is if a patient lives far from a center or doesn't have transportation, then they don't make it to radiation at all. And so there's a compliance issue. And with GammaTile, sort of one of the most important quality of life metrics, I think, is having some peace of mind knowing that the radiation has started. I think both for the patient and their family and the provider too. We're following quality of life metrics on our clinical trials that we're currently running.
Let me follow up with this, and I'll have you and both Dr. McCracken speak to this a little bit. Dr. McCracken, I'll start with you. All of you guys have touched a little bit on who qualifies, like who's a good candidate for GammaTile. Is there a patient that wouldn't be a good candidate? Like, is this something that, can you use GammaTile on somebody that has an inoperable brain tumor? And if you can't, what's the theory behind that right now? Like, why not? And then to follow up on that a little bit more with Dr. Garcia, you had also mentioned, I'll have you guys piggyback off each other, but you had also mentioned that this can be used in recurrence. So somebody who's newly diagnosed can have the GammaTile put in and start their radiation process. But then if somebody has a recurrence, this can also be used again. I just want to, is that correct? Before I hop over to McCracken, sorry.
Yes. So there have been multiple reports published on using GammaTile in the setting of previous external beam radiation.
Wow.
In fact, I would say that that's where most of the data is right now, and we're acquiring more and more data in the newly diagnosed setting. There's existing data, and we're further evaluating on clinical trials that are enrolling.
Wow.
Yeah.
So Dr. McCracken, let me hop over to you and have you answer the question that we were just talking about. Who does this work for best? Like, who is a good candidate for this, and can it be used on an inoperable tumor? I've met a number of patients who have said their tumors are inoperable, and so choices are limited. So can you speak to that a little bit?
Yeah, so I think, let me first start off by saying, initially when this was, FDA approved, it was really only approved in the recurrent setting. So patients who had recurrent GBM, recurrent metastases, recurrent malignant meningiomas. And then as the data came out, it was ultimately approved for the treatment of newly diagnosed malignant tumors, right? So, those were sort of the patients that we looked at, and it really opened up the door for who we could treat this for, right? So it wasn't just these salvage or palliative care patients who had already had a million different treatments and really had no other options. It really opened up the door to treat patients in the upfront setting, which I think has been tremendously helpful. And I think the data will ultimately show the good long-term effects of being able to do that. But ultimately, your question is about patient selection. And it's really important because we've had a lot of patients come to us and say, am I a candidate? And people, we have to tell no. And it's because, number one, they have to have a tumor that we either know is a malignancy and will likely need some type of radiation supplementation, right? So for a lot of non-malignant tumors, a lot of those patients don't need radiation, right? So things like benign meningiomas, benign acoustic neuromas, grade 1 types of, glial neoplasms, those patients typically don't need adjuvant radiation therapy. So we don't even really consider those.
Okay.
So for patients who do have either known or presumed malignancy, those patients are always going to need some form of adjuvant radiation. And in the past, it's typically been external beam, right? Either hypofractionated, fully fractionated, or stereotactic radiosurgery.
Yeah.
From a surgical standpoint, we really want to make sure patients can either have what we call a gross total resection or a near total resection, which means that when we are going in to remove tumor, we feel that we can remove as much of the tumor as we can physically visualize with our eyes, right? So that what's left is really just microscopic disease, and that's what the radiation begins to work on. What we found is challenging is that if you leave more than that, the depth of penetration from the radiation typically doesn't work as well, and you can have disease progress outside of basically the range that the GammaTile can work in, and then you're having to supplement with external beam as well.
So can I just jump in real quick and just ask for everybody who's watching, what's the difference between gross total resection and near total resection? What's that difference?
So a lot of it are radiographic terms, right? There are different definitions, but basically a gross total resection would be, your surgeon comes after surgery and says, I got 100% of the tumor, right?
Okay.
Or I got 99% of the tumor. And then your MRI would confirm that anything that was in the contrast enhancing portion of the tumor that they showed you prior to surgery is basically gone. Okay. That's what we strive to achieve, with almost all of our surgeries. Sometimes that is preventable or prevented by, going up into an eloquent area or functional tissue, right? So we always balance an oncological resection with functional outcome, right? So we don't want to potentially knock out somebody's language center or their motor center just to get an extra 5% of tissue, right? And so a near total resection may mean, well, I got 90% of the tumor out, but I had to leave a small portion behind that if I would have taken that would have caused a significant neurological disability. Okay. So those are the kinds of attempted resections we are trying to be able to achieve. And so when we look at an MRI beforehand, if I go, there's no way I can get all that out, right? Or I can only maybe get 50, 60% of that out, GammaTile is probably not going to be effective. Okay. It may be effective locally, but you're still going to have tumor beyond sort of the depth of penetration of the radiation, which would still need supplementation with like an external beam plan. So for patients that we really look to include are, certainly, are they healthy enough for surgery? Do they have a reasonable life expectancy to undergo surgery in the first place, right? And is this tumor accessible, and can I achieve hopefully either a near total or gross total resection of the tumor? Those are the things that we always look for up front. And then, to bounce off Mike's, previous statement about compliance, I think two of the biggest things that we've seen this be very effective for are, number one, patients who are going to have trouble with transportation afterwards, right? So they're going to have difficulty, just whether it's a financial standpoint or family support standpoint, getting to and from a radiation center.
Right.
Are they too far from it? Do they not have the means to do it? That's a great way to be able to give them sort of a built-in compliance. And then the second thing, which I think is tremendously important, is in most states, patients who have to go to an inpatient rehab facility in general cannot go back and forth to get rehab, or excuse me, cannot go back and forth to get radiation. So if you are getting an inpatient rehab treatment, you likely cannot start your external beam radiation. So there are patients who come to us that we know even before surgery that these patients are going to need rehab, right? They can't move their arm or leg. They can't walk. These patients are not going to be well enough to go home to ultimately be able to come back and get outpatient radiation therapy. And so those patients that we are aggressively discussing GammaTile with, because we know there's going to be a delay in their therapy. So we can resect the tumor, we can put in GammaTile, and then feel very confident about them going to rehab for 6 or 8 weeks, knowing that they are getting radiation therapy and not going to have a delay in their external beam.
So let me piggyback off of this a little bit, and then I'm going to jump over to Dr. M. With GammaTile, when it's inserted at the time of surgery, even from the very first surgery, now that obviously there's some newly diagnosed GBMs that are qualified for GammaTile, can it delay or prevent a patient from needing other multiple surgeries? So if a patient gets GammaTile right out of the gate after their surgery, can it possibly delay a recurrence of the GBM coming back? And to piggyback off of that even further, there's a lot of evidence that shows that multiple surgeries causes more cognitive deficits, more scar tissue builds up, there's more necrosis. The more times you have to go in and operate, the more deficits and problems are caused. Can you speak to that a little bit and how GammaTile can play into the benefit of maybe having that be delayed or not having to have as many surgeries down the road?
Yeah, so let me first start off by saying, providing GammaTile in the upfront GBM setting is a relatively new concept that has really not been done extensively up till now, right?
Mm-hmm.
There's currently a feasibility study, which is basically a precursor to a randomized controlled trial called Gestalt,
Okay.
which is basically looking to enroll 61 patients across the country into basically determining the safety of patients getting a resection plus GammaTile for upfront GBM, and then safely going on to the rest of their adjuvant treatment. Okay.
Mm-hmm.
So if we can show a positive benefit in that feasibility study, that will ultimately translate into a clinical trial. So what I will say is that we don't have a dearth of data
Mm-hmm.
showing that does this prevent recurrence, longer than sort of traditional therapies. But I'm very hopeful that a lot of our data will show that by treating these patients early, ultimately it will sort of delay their progression. Okay. Now, with respect to does it prevent other surgeries? I would say the vast majority of patients, don't need an immediate new surgery right sort of during the perioperative phase or during the initial chemoradiation sort of Stupp protocol phase. Now, some patients need things like, if they get a wound infection, right, certainly that may delay something. We have to wash out a wound, or they
Mm-hmm.
develop hydrocephalus and they need a shunt.
Mm-hmm.
We've treated both of those patients, and GammaTile does not prevent you from doing that, right? So
Right.
it's just like they were getting another form of radiation, and we step in and treat them just like we would any other patient. And so, I think you're right when you say, the more times you have to go back in for whatever reason, right? They've had a progression, they've developed hydrocephalus, they've developed X, Y, and Z, right? Every time you have to intervene, that does put somebody at risk for having more complications. But I would say for all the patients that we've treated so far, well over 1,000 patients nationally,
Wow.
I don't think there is a higher incidence of, complications related to, you know, from a retreatment standpoint after somebody's received GammaTile. So in
Okay.
general, I think it's a very safe therapy.
Mm-hmm.
And it's something that we're still treating patients like we would. It has not increased the incidence of complication by any means.
So this actually this is a great segue over to Dr. M. Can you talk a little bit about some of the side effects, if any, of GammaTile when it comes to the actual process of the radiation that the GammaTile emits?
Absolutely. I just want to there's some thoughts that Jay's conversation generated I just want to mention. So you had asked a previous question about can GammaTile be used when a tumor is inoperable? And,
Yeah.
of course, I agree with what Jay said. The answer to that categorically is kind of no. If you can't operate, you can't do GammaTile. But I will say that having GammaTile as a tool that is relatively new has changed the way we approach which patients can actually have surgery,
Mm-hmm.
right? For
Mm-hmm.
example, it really used to be the case where someone has received maximal dose external beam radiation and then they recurred. We really were hesitant to give any additional radiotherapy because they've already reached their max point. And at that point, it's diminishing returns. You're much more likely to cause toxicity and possibly even demise by giving additional radiation. And this speaks to the question you just asked me about the side effects, but
Mm-hmm.
due to the fundamental way that GammaTile is different compared to external beam, it becomes viable, if not even very safe, to give GammaTile type radiation right in the middle of a prior external beam field that's received a tremendously high amount of energy and it be safe.
Mm-hmm.
So to bring it back home, whereas we might have 5 years ago said this patient can't have surgery, not because it's not a surgically possible, because it wouldn't benefit them, at least in the long run. Now we have this adjunct therapy, which piggybacks off of the surgery, and giving
Mm-hmm.
surgery plus GammaTile is fundamentally different than just surgery alone. And so I do think it changes the way we approach which patients are candidates for surgery. And to that point, I've done at least one case where a patient recurred after GammaTile and we did surgery again. Like we removed
Okay.
the old area where the GammaTile was when we put in another GammaTile. And
Oh, interesting.
so you can kind of start thinking very creatively about these type of patients in really individualized care. So then to bring it back to your current question about side effects, it's very well tolerated, almost safer than other forms of radiation that give similarly concentrated doses like gamma knife or stereotactic radiosurgery. It's almost to the point where, I mean, you have to consider these typically are patients that up to, like Jay said, up to almost now where have all been in the recurrent setting. So they're all heavily pre-irradiated patients. They've already received radiation therapy. You would think that giving them additional radiation would actually cause more side effects just from that bias.
Right.
But then say that they're so well tolerating this treatment, and we don't see side effects that are worsened because of giving additional radiation, kind of makes you think very positively that this is well tolerated. So to simplify it, no hair loss, no burns or things that people might worry about. And I counsel people on, there's a risk inherent to the procedure, of surgery and anesthesia and healing, but they're not increased by using GammaTile.
Right. Right.
And just to
That's,
piggyback off of that,
yeah.
we're tracking all these things, complications as part of our post-market surveillance. We have a robust program for tracking all of these things. And we also have a registry of patients. It's a multi-institutional study where over 350 patients have been enrolled who have received GammaTile. So we're tracking all these things very carefully. And in terms of surgical complication, we're not seeing any surgical complication at a higher rate than a craniotomy without GammaTile, for instance.
I was going to say, as it pertains to the GammaTile, I mean, obviously there's always a risk when you're doing any kind of surgery, let alone a brain surgery, but there's no other.
Based on everything based on everything we're seeing as part of post-market surveillance and from our large registry study, we're not seeing any additive risk to the craniotomy.
Now, this almost makes me, and I'm going to jump into, we're going to stick with you, Dr. Garcia, because we're going to talk about Rhodes, and is there a difference between what Rhodes is and what GammaTile is? I want you to speak to that a little bit, but, this really has me, as we were talking earlier about the radiation beams and kind of shooting out and hitting the floors and hitting other areas of the head. You almost wonder if, because it's in such a contained space, that maybe that's part of why there's a reduction in symptoms, because the radiation isn't hitting so many other areas and you're not having the radiation wall and the sickness and the nausea. Could that possibly be part of why there's limited or less symptoms or side effects, because it's contained in the cavity instead of having these beams kind of shooting all over the place?
That's absolutely true, especially when it comes to hair loss, because the beams are not having to traverse the head. The hair follicles are not sort of innocent bystanders for GammaTile. Plus, the skull itself stops the dose, attenuates the dose. So the radiation dose is not going to the hair follicles and the skin like it would for external beam radiation. And I think even just traveling daily, to a hospital or radiation center can be tiring for folks. So, but that's a good lead into what Rhodes is. So Rhodes is the name of a clinical trial, and we have 4 clinical trials. Jay mentioned Gestalt for glioblastoma, which I could talk a little bit about as well to piggyback off of what he said. He explained it really nicely. And I'm grateful for both Imran and Jay for enrolling on clinical trials, especially Gestalt. Rhodes is a different clinical trial. It's a phase 3 multi-institutional randomized clinical trial for newly diagnosed brain metastases. So for small brain metastases, radiosurgery, external beam radiation radiosurgery does quite well. You can pinpoint the radiation. Even from an external standpoint, you can give high doses of radiation to really small tumors. Brain metastases are when cancer spreads from the lung, for instance, or the skin or the breast to the brain. And little cells then grow into tumors, and those need to be addressed in addition to chemotherapy with radiation. And so radiosurgery can do very well for little small tumors. However, for big tumors that need surgery, radiosurgery does not work so well.
Okay.
Radiation, remember, we have to give radiation after removal of these malignant brain tumors because they can come back. And so to date, the standard of care is surgical resection of a big brain metastasis and then external beam radiosurgery. But that leads to local control rates that are not great.
Right.
And so Rhodes is looking at using GammaTile instead of radiosurgery. So it's a comparison between GammaTile placed immediately at time of surgery versus external beam radiosurgery, which typically starts again 2 to 4 weeks later. The problem though is we know for brain metastases that are resected, if you wait past 4 weeks to start the external beam radiation, the chance of the tumor coming back goes from 2% to over 20%.
Yeah.
And it's not easy to start external beam radiation within 4 weeks. And so a hope that we have in doing GammaTile is that by starting radiation immediately, we can improve outcomes for patients with brain metastases. Now, GammaTile is not meant to replace radiosurgery, of course, altogether. I think it's to add another tool to the arsenal of the doctors. And so, for instance, for Rhodes, oftentimes these patients have more than one brain metastasis. They have a big one that needs to be removed, and then they have some smaller ones that don't need to be removed. And regardless of the arm that the patient is on for Rhodes, they'll receive radiosurgery. And so it's by no means meant to replace external beam radiation, but to just add to the arsenal for the doctors and the patients.
And you kind of touched on a really key point, and any one of you can chime in, but if I'm not mistaken, and correct me if I'm wrong, but when it comes to whether it's a metastases and these cells have gotten into the brain, or it's generated, it's glioblastoma, it's brain cancer, it's started in the brain, the cells migrate, they triple, like they double and triple very, very quickly, if I'm not mistaken. So waiting 4 to 6 weeks to start radiation, I mean, isn't that part of the problem, is that, you know, like you're going out and you're resecting this tumor, but then you're giving it time to regenerate because nothing else is going on in between that waiting period for radiation to start.
This is exactly why I think GammaTile is such an important modality. And to piggyback off of what Jay said earlier, patients, when they have to go to rehab, for instance, or they have a prolonged period between surgery and starting radiation, you're absolutely right, Shannon. The tumors can start growing back. We know from a study that was published a couple of years ago for glioblastoma that you can visibly see tumor that has grown back between surgery and the start of radiation in almost 50% of people. And that's associated with worse outcome. When we see that, we call that rapid early progression. And the University of Minnesota recently published a paper. They looked at patients who had surgery with a plan to start external beam radiation, but unfortunately their tumor grew back to 100% of what it was before surgery. So the tumor just came right back. And they looked at the patients, it was a series of patients. When that happened, they took them back for surgery. They implanted GammaTiles. And then they added on the external beam radiation. The reason doing both together is important for glioblastoma is because glioblastoma is an infiltrative tumor. And so our Gestalt study, it entails patients having their glioblastoma removed with surgery, placing GammaTiles to start radiation immediately right at the surgical cavity, which is the most likely place for the tumor to start growing back right away. And then a few weeks later, add on external beam to add on a little bit more margin to account for those infiltrative tumor cells. So for Gestalt, you use both GammaTiles and external beam, but you use less external beam, 4 weeks instead of 6 weeks.
So now these, before I move on to the next question, just very quickly, the Rhodes study and the Gestalt studies, that's how it's pronounced. Are they both recruiting currently, or is the Gestalt study? Okay, they both are recruiting currently. So very quickly, where can somebody go if they're interested in this, or they want to maybe possibly learn how to participate in this in one of these? Where can they go to get that information?
Well, so both Dr. McCracken and Dr. Mohoudin are enrolling their principal investigators on these studies. So Advent, and
At
also
Advent Health
Piedmont.
and at Piedmont.
And,
Okay.
and there's a number of other centers that I'm sure would be more geographically closer to some other listeners that are in other parts of the country.
Okay.
Both of the
But we
trials,
also, on we have a website too where it just lists the sites. Yeah. And then clinicaltrials.gov also would list where the enrolling sites are.
And Dr. Mohideen, what were you going to say?
I was going to say exactly what Mike
Okay.
said, that there's websites that list where a patient can have the closest center that has that study available to them.
And I will post some of this for everybody who's watching, and those who are watching the live stream, or anybody who watches after. I will make sure to get this information set up so that people know where they can go to learn about getting recruited, or if they can get into it. As we're talking about this, since we're talking about locations, Dr. Garcia, can you tell us currently how many sites or facilities across the U.S. are currently enrolled and using GammaTile in their hospitals and radiation settings?
Yeah, to date, there have been over 100 centers that have used
Wow.
GammaTile, and that's being added to monthly. And to date, over 1,400 patients have been treated with GammaTile, both on trial and off trial. As Jay McCracken mentioned earlier, we have an FDA clearance, so these patients can be treated off trial, and we're conducting the trials to just further validate the data that has been acquired off trials.
And you said 1,400. 1,400 patients. Wow. So I'm going to go into dream world a little bit here with this next question. And we do actually have a couple of questions that have popped up. A couple of them are very good. I'm curious, since GammaTile is being used, like GammaTile, it breaks that blood-brain barrier. We all know that this is the problem with brain cancer, is that breaking that blood-brain barrier for immunotherapies, chemotherapy, like this is one of the struggles. This is what makes it so hard. The brain is very well protected. And that's what makes this cancer so dangerous and so aggressive. But GammaTile is already in there. It's already kind of broken that blood-brain barrier. So if we can go into dream world a little bit, Dr. M, Dr. McCracken, is it possible maybe at some point down the road that the way that we're using GammaTile, maybe we can use this type of therapy that you guys have introduced? Is it possible to do this for chemotherapy, where it's maybe used on a tile and inserted directly at the site of the cavity? I mean, is that even remotely, not that it's being done or, studied currently right now, and I will put that out there, but thinking into the future, if we can get this innovative with radiation, can we do something like this for chemotherapy?
So I'll start, and I'm sure my colleagues have plenty to add to that. One, I'll just mention all radiation penetrates the blood-brain barrier, because remember, it's X-rays. So the blood-brain barrier, radiation just goes right through it. But
Right.
to your point, GammaTile is very unique in the way that it does that.
Right.
What I love about GammaTile is that it does not, as opposed to external beam, it doesn't preclude concurrent therapies.
Well, that's a good point.
What I mean by that, like, for example, if you're being treated for a lung cancer, radiation oncologists get very nervous about giving you concurrent chemotherapy while you're on radiation, because there's this concept of radiosensitization, meaning you can damage the local tissue with radiation if it works too well, if there's too high of a synergy with a chemotherapy. Now, this isn't always the case, as you know, with glioblastoma, part of the modality is giving it with chemotherapy. So it's very tissue dependent, reagent dependent, chemotherapy dependent. But as a whole, with GammaTile, at least in my practice, I don't even worry about it. So if the patient's on immune therapy, on chemotherapy, on tumor treating fields, just pilot it on. And I think that is rational, based again on some of the things that we've kind of said is beyond the scope of this conversation, but I'll mention it. It's a low dose rate radiation. It's more like it's more gentle on the tissue, and that permits this concurrent therapy. The other thing, you mentioned immune therapy. My PhD is in immunology, so this is something that I'm really excited about. But immune cells, one, I think it's a very hotly debated whether immune therapy needs to, like, the reagent itself needs to cross a blood-brain barrier, because immune therapy works by educating the immune system, checkpoint blockade. So it doesn't actually have to cross the blood-brain barrier. It just has to educate the immune system, and then the immune system crosses the blood-brain barrier. That's a little bit beyond, again, the scope of this conversation, but we know that immune cells themselves are exquisitely sensitive to radiation. Like, they just have to get one shot of radiation and they will die. Immune cell,
Interesting.
white blood cells. But again, the GammaTile is so gentle and it has such, by design, a limited range. You know, I think that it's very attractive to think that the GammaTile application preserves the immune milieu of the brain. It doesn't wipe out the immune system that's already in the region, ready to pounce. And by being of that type of gentleness, then that permits the immune system to better be able to respond. I think,
Good
obviously,
point.
what we're said, we're in dream world, and I would love for this dream to come to fruition, but those are areas of active investigation. To your question about, you know, localized chemotherapy, that has been tried before, you know, so that doesn't mean, though, that we can't revisit it and get better and more clever with it. I mean, to that point now, there's talk about using like focus ultrasound and micro bubbles to very selectively open up the blood-brain barrier, and things like that. So I'm excited about the future holds, and you know, I think that will be very exciting.
Dr. McCracken, do you want to add to that at all?
Yeah, I mean, I love your idea of sort of thinking about sort of next applications for, how we're going to use this. And I think we're sort of really, getting into the data for, what this was designed to do, right? And we're sort of, the data is really starting to compile, which I think is wonderful. I think as we think sort of future in the long term, there are so many types of other cancers and locations throughout the body that I think that can benefit from a similar technology. So I think immediately, we are thinking of different ways that we can apply a GammaTile to even a different area of the brain, maybe even in a more minimally invasive fashion, or different applications as opposed to just the single tile, how we're delivering it.
Yeah.
And then we've also sort of thought about, can this be used in, head and neck cancers and spine tumors and things like that. So, I think there's a lot that I think that this could ultimately, become a part of, that we're really relying on just basic sort of external beam radiation now. So, so I think we'll see. I mean, I think it's a really exciting field, and I think it'll be tremendous to see what other applications that we
It
can
is
come up with here.
exciting. I mean, I'm very excited about GammaTile. I think of so many different things and how there's so many other applications that I feel like it could be used for, and it goes beyond the scope of this conversation. But this is the kind of innovation that we need when it comes to treating such aggressive cancers like brain cancer. I mean, we need to be thinking outside the box. We need to be using all of the tools in our arsenal, and GammaTile speaks directly to that. I mean, this is a prime example of the kind of technology and the kind of innovative tech and treatment that we need for aggressive brain cancer. With that, and I will have my close with just kind of some futuristic, where do you guys hope GammaTile will be, in the next 3 to 5 years? But we have a couple of really good questions. The first one that I want to ask, and this was brought to us before we started, is GammaTile covered by health insurance? Is it covered through a health insurance program, or does somebody have to pay out of pocket?
So I'll just say that, GammaTile is ultimately considered a surgical implant.
Okay.
So that is covered within the cost of surgery. So ultimately, if your insurance company approves your surgery, then ultimately the money that a hospital receives from the insurance company for the surgery, ultimately it comes out of that bundle of money. So yes, that is not something patients pay for out of pocket.
Okay. And the next question we have is it safe for other people to be around the patient that's implanted with GammaTile? And this is an interesting question. I believe this comes from a caregiver. So is somebody at risk of exposure? Is it safe for them to be around somebody who's had the GammaTile implanted?
That's a great question.
Yeah.
And it's a really important question. So the dose or the activity of the radioactive seeds within the tile, the half-life is 9.7 days, meaning every 10 days, the activity drops in half, and then in half, and then in half. In other words, at about a month, the patient has received about 90% of the total dose. I mentioned before that the skull itself kind of blocks the vast majority of the dose. Memorial Sloan Kettering published a paper where they looked at 22 patients and they looked at the healthcare providers, the surgeons, the nurses in the hospital who were around them, and they wore ring badges, which sense radiation.
Mhm.
And then they also modeled the amount of radiation that their family would receive. And both healthcare providers and family members were well below the regulatory limits of what is considered safe. But many doctors will counsel their patients out of an abundance of caution to say for the first few weeks after surgery, avoid sleeping next to a loved one because your heads may be close to each other, and that's sustained. It's out of abundance of caution.
Okay.
But otherwise, I mean, it's been studied, and it appears quite safe. You don't need to isolate away from family or friends during the
Interesting.
postoperative period.
So there was another question that came through through our live stream version. Somebody who's had, whether it's regular external beam radiation or the GammaTile, if the patient gets sick or throws up, whether it's due to a radiation sickness wall or chemotherapy, is the family member exposed because that patient got sick? Because are they exposed to any of the radiation that way?
No, they're not. And so remember the radioactivity comes from these tiny little seeds that are the size of a grain of rice inside of a postage stamp size
Crazy
collagen
that it's
tile.
that small.
And that the seeds stay in place. So this is not like chemotherapy or some other form of liquid radioactivity that's put in the blood and can go through the body or taken
Okay.
as a pill, such as
Yep.
radioactive iodine. So if somebody gets sick and vomits during external beam radiation or having had gamma tiles, that is not radioactive. Yeah.
Okay.
The
The
urine's
last
not
question,
radioactive either.
the last question we have is GammaTile similar to brachytherapy? And if not, what's the difference?
Yeah. GammaTile is brachytherapy or
It is.
brachytherapy, depending on what side of the Atlantic you're on. So like brachy essentially just means near, as opposed to teletherapy, which is external beam radiation, which is far. All it means, breaking down the word, is that the therapy is near the target, and there's other forms of brachytherapy that you use for prostate cancer, for gynecologic cancer. So in itself, it's nothing new.
Mhm.
It's actually probably one of the oldest forms of radiation therapy that we know of. And this just falls under that category.
Okay.
It's a great description. And I'll just mention off
Yeah.
of that what GammaTile has done is allowed brain brachytherapy to be done in a much easier and faster fashion than it has been in the past. The first brain brachytherapy case, to my knowledge, was 1936. But
Wow.
brain brachytherapy has been technically challenging and has added time to the procedure, a significant amount of time, and has been technically challenging. And it's been hard to control dose because the radioactive material can move around or be displaced, and the collagen tile keeps things in place. And so for this reason, before GammaTile, brain brachytherapy was available at less than 10 centers across the US. But since GammaTile has been commercially used, we're in over 100 centers. So it's brought brain brachytherapy access and has made it much easier and allowed it to be better studied. So
wow. So Dr. Garcia, where do you see, as we're talking about all these centers that are available to people, if people are in this situation or want to learn more, or, there are centers across the US. And I do know that GT Medical, GammaTile Therapy, there is actually an interactive map on the website that shows where all of the centers are located for people. But where do you see GammaTile, or where do you hope to see GammaTile be in the next 3 to 5 years? Where do you hope to see this, specifically with the Rhodes study and Gestalt, and where do you hope to see it?
I feel really passionate about patient access to innovative therapies.
Yeah.
And so I hope that we'll be in even more centers than we are today so that more and more patients have access. And I think that especially, I'm hoping that the clinical trials finish enrollment this year. As Jay mentioned, Gestalt is a safety and feasibility study. And if that finishes this year and everything looks good, then we're going to do a randomized study for Gestalt. So that's a hope that we have for Gestalt.
Okay. So I would love to thank all of you. I will say, for everybody who's watching, if you do want to learn more about the studies that we were just talking about, you can go to rhodesstudy.com, or you can go to Gestalt. It's GESTALT trial.com if you want to learn more about either one of those. I thank you all so much for joining us today, for doing this, for giving us this information. This again is GammaTile is so vital and so important to the work that all of you guys are doing. And it's also so vital and so important for patients and their caregivers and their families and their loved ones to know about. This is the point of patient advocacy. This is the point of education, is giving as many tools and arsenal and information to a patient as possible so that they have everything that they need at their fingertips as they're learning about their diagnosis. We already know it's extremely overwhelming when you're getting the news. So to be armed with as much information as possible, and that's what sessions like this and webinars like this are all about. They're all about teaching, advocating, educating, showing the innovation and the passion from doctors like you guys that really want to do what's best for the patient. And that comes through loud and clear from all three of you. You're brilliant minds. We are really lucky to have people like you working in these kinds of fields and to be as passionate as you are. So thank you so much for joining us today and for answering these questions and for giving us this information.
You're welcome.
Thank you.
So everybody, thank you so much for joining us. And we will have this recorded. So anybody who missed today's session, you will be able to find this afterward. We will post this after the live session is done. And thank you so much. We will see all of you later.
Bye.